So thank you, Dr. Kishore, for coming on this podcast. We do a podcast called as Healthcare Tribe. It's primarily cover healthcare journeys of leadership journeys of people in healthcare.
Thank you for having me.
It's great to have you. A lot of my team back there is damn excited about having you, and they already have lots to know about you. But at the same time, what I intend to cover today, at least some areas, and some of it will be free, absolutely freewheeling, but some of the things that I will like to cover for our audience is, one is your background of pediatrics and neonatology. And entire experience in birthing. We definitely would love to know from you what should a mother be doing, right, or a to-be mother should be doing, and also what are in the early years critical areas of care that people should take, and areas around that, right? So the birthing and childcare, your expertise will definitely love to cover that part, and I'll definitely love to cover that part. And the second is this entire story of Cloudnine and entire economics and the business behind the Cloudnine Birthing Center, and how that is serving a certain section in the country, and how did this category merge. So these are two broad areas that definitely will cover. Sure. Apart from that, of course, we will cover many other things interesting about your life. Absolutely. So let's start there actually. Where did your interest in pediatrics started? You were telling me a story earlier about you wanting to become an engineer but landed up becoming a doctor. So tell us a little more about it. How did that happen? And then how did pediatrics happen? And what made you do this?
Yeah, no, I always had liking for both the mathematics and biology. It was a very, very difficult choice to choose one or the other. So now when I look at the options available in the West, I feel that we should have had that liberal arts sort of education, combining the mathematics and biology. So in my year 12, I had taken PCMB, and I probably, if you take the choice between mathematics and biology, I preferred mathematics and chemistry more than biology. So I stood first in PCM for the state. So I landed up choosing engineering software, that too in UVC. That was the prime institution at that time. And I was the first in the state, so I got that. And that was the first batch of engineering where the engineering course was reduced from 5 years to 4 years. So I was pretty excited because, if you look at a medical person, you become a doctor after 6 years, whereas you can become an engineer in 4 years. And I was always planning to go to US and do MS and come back and do some industry.
Which was this year?
This was 1980.
So even in 1980, you were clear to go to MS. It was much before the craze of going to MS started.
Correct. It was.
Yeah.
So I got the interview, got the seat, and I joined USC. In fact, I went to the class and I sat in the place where I was going to sit and came, and I told my grandmother that I'm going to become the software engineer and I'm going to do this. And I was very close to my grandmother, my mother's mother. And she said, "Oh, you are also becoming an engineer." And she sounded very despair. And I said, "What do you mean by you are also becoming an engineer?" She said, "Your mother always dreamt of one of you becoming a doctor. And she has 4 sons. I have 3 brothers. So she said, you are the last one. I'm the youngest." So she said, she was hoping that you will become a doctor.
All 3 brothers are engineers.
So I said, she never spoke about this. So then I applied by medical and also landed up becoming a doctor.
But for her, you were okay to change the field and go to medicine.
That's right. As I said, I enjoyed both mathematics and biology, but probably my inclination was more towards mathematics. And once I joined medicine, I was always interested in children, because children recover faster, and the smile which you get in a child who recovers from an illness is such a rewarding experience. And so I always wanted to become a pediatrician.
So even while you're doing your MBBS, you are clear that you would want to do a pediatrician.
Correct.
Yeah. Yeah. Wow, that's nice. Now, looking back, do you feel you should have gone to engineering, or you're very happy that you landed up doing pediatrics and neonatology?
No, I'm very glad I became a doctor.
So your grandmother did the right thing for you then.
Absolutely, yes.
And definitely did right thing for many children.
Yeah.
But yeah, that's quite interesting actually. You are I always say there are more number of people that I know who have wanted to become a doctor but became engineer, including me. My father is a doctor, so I had always had a fascination to be a doctor in the initial days. But when I got the admission, I also took PCMB, but I was getting the college that I wanted to get into for medicine. My marks were not enough to get there, but was getting into some other college. My father never pushed me to be a doctor or either. He said, this is something that if you have real commitment and interest, you should do it. I had, by the way, but then I was like, if I have to be a doctor, I should get into, my father is an MD. Medicine, so I have to get something bigger and better, and then eventually I took engineering because I was getting much better college, and again I had a very similar thing. I had liking for both, but my first preference was to be a doctor. And a lot of people I've seen in healthcare who are not doctors but are still committed in healthcare are actually those who wanted to become doctor. In my recent podcast with Dr. Vimal Raj, he was one of the person that I met who wanted to be an engineer and landed up becoming a doctor. You are the second one that I'm seeing. But anyway, so that's your journey into pediatrics, and then you started. You did your pediatrics from.
I did from Davangere. Dr. Nirmala Kesri, she's late Nirmala Kesri now, but. She was one of the most visionary leaders, and she was a pioneer in a different way because she was the highest qualified pediatrician at that time anywhere in the world. She had triple FRCP, she had DABP from USA, she had MD from India, she had all sorts of degrees, and she had innumerable numbers of articles she had published in her name. But she always wanted to come back to India, though she had various offers in various places.
And she was, where was she?
She was in Davangere. She was our professor and head of the department. And then we had a great teacher called Dr. Kulkarni, Murli Kulkarni. And the passion and the amount of learning we had from these two were enough to propel, and in fact most students who studied pediatrics from Davangere under these two professors have excelled in their life. Majority of the successful pediatricians now in the world are all Davangere because of these two.
Oh really? So you think these two professors through their teaching influenced a lot about what you finally went on to become as a pediatrician, the way you practice?
I mean, I was interested in pediatrics, but I think I found the right teacher there. I mean, that's probably, it's like kindling your spirit in a bigger way.
Right. No, I have seen that impact actually because, so my father, as I was telling you, he's a doctor, but he loves teaching. And he has been a professor as well. So he used to practice, the college allowed him to have his private practice, because I think without private practice, the unfortunate reality of the country is that teaching doesn't pay.
Absolutely.
But he had immense passion, and he taught for like 15-20 years of his life, along with doing his private practice. And I've seen some of his students, right, so moved by his teaching, that they still send things like mangoes to the house. This is 30 years, right? And we are in the family really feel proud about that. But so that's an interesting point. So this teaching shaped you. What would be a couple of things that you think it made a difference from your practice perspective? What would you say after looking back reflectively on it? How did they shape you?
One is it propelled me to become a very good academician. Because see, any doctor is a good clinician once you train yourself. But not all clinicians are academicians. And I was
That's
propelled to become an academician. And the third thing is, you can be a clinician and an academician, but not a good researcher. The mind to get involved in research was kindled again in Davangere.
Oh, okay.
So not all doctors are good clinicians and good academicians and good researchers. There can be either one of them, but we were sort of propelled to become good in all three.
And what would be the difference between an academician and researcher, just for...
Like, you can be good teacher teaching students and other things, but you have never done any research on your own.
So academician, you would mean someone who teaches well.
Teaches well.
Okay, got it.
And researcher is somebody who thinks,
Of course.
how can I do this better tomorrow?
So you got these three components from there.
Absolutely. So the seeds were laid there. But once I finished my MD, what I realized is India lacked specialization in neonatology, which is the first year of life of the child.
Absolutely.
And all over world, there was specialization in neonatology. So I definitely wanted to go and specialize in neonatology and then come back. That was my motto. So that's when I left soon after my MD.
Where did you go for?
Well, those days going abroad was not easy. So soon after my MD, I worked for a few months. I thought I'll work in Mysore, Mission Hospital. And when I worked in Mission Hospital, a lot of things happened, so which made me stay in Mission Hospital for a year rather than a few months. So after a year, I left for UK.
For UK? Oh, okay.
So I went to UK for a year, and before I went to UK, what happened is in Mission Hospital, we saved a small baby who was 780 grams. And when that baby survived, that was the smallest baby that had ever survived in India at that time. So it was in newspapers, television.
How many grams you said?
780 grams. And nobody had heard of any baby less than 800 grams surviving in India at that time. So instantly I became so popular, but my inner fear was there, whether the baby survived on its own or did I do something to make the baby survive. But that was that time. But today we constantly save and we replicate our success in saving babies less than 400 grams in Cloudnine.
Wow, that must be a journey, isn't it?
Absolutely.
So yeah, let's go into that journey then. Actually, is how much of a problem it is today. So let's go directly into those birthing and neonatal care. Today also, if I understand right, the specialization of neonatology in India, though, is far better than what it used to be at that time, but it still is very underpenetrated. Is that right when I say that? Or you see significant and sufficient enough of neonatologists in the country?
No, we have a good training now, and we have sufficient lot of people trained now. But the penetration of neonatologists in rural areas is not much.
Of course.
Now, the urban area, the care, for example, in Bangalore, the neonatal care is as good as anywhere you can get in the West.
Yeah.
But if you move 50 kilometers from Bangalore,
exactly,
the care is
drops significantly.
So there is an imbalance between the urban and rural areas neonatal care in a big way, and that needs to happen, and that can happen only with political will and all the support from the government also. Just the doctors alone can't do anything.
What kind of support?
Well, when we started Cloudnine, how we were closely associated with the GE.
Right.
And that's where I met you first.
Yes.
And we wanted to create a similar standard NICU in a rural area. And GE was ready to sponsor all the equipments, and we were ready to put all our brain thoughts into infrastructure was being donated by somebody. But what we realized is this place had already on paper 3 pediatricians working, but they used to come once a month and sign the paper and go. One of them happened to be related to minister, one of them happened to be related to some IAS officer, and another happened to be relative of some MLA there, and they had the equipment, but they had never been opened. They had the good incubators, good resuscitators, but they had not even opened. And the politics and the pressure was so much that we abandoned the idea of opening this NIC in the rural area.
Oh, really?
And they didn't want to, because the moment you open, suddenly these people who are coming once a month to sign will get caught. No? So
the people working there didn't want. But wouldn't government do anything to orchestrate that change? No, despite putting pressure.
It's a complex problem. I think it's beyond our podcast to talk about it.
I get that. But you're saying if there is a will, there is a way.
Absolutely.
And a lot. It's not about being a poor country or.
No. In fact, India is a rich country. I keep telling this everywhere. India is a rich country with a poor administration and poor people.
That's an excellent point. Yeah.
West is a poor country, but a rich people and rich ideas. And unless we have a political will to improve the health services, which is a state subject, it cannot be done. See, Kerala and Tamil Nadu have the political will, and their indicators, for example, if you take neonatal mortality rate, maternal mortality rate, which are the indicators of a standard country to become a developed country, are on par with the West. So there's nothing stopping Kerala and Tamil Nadu to achieve single-digit mortality. And we, just 50 kilometers above that state, we still have mortality in triple figures. I mean, it makes no sense.
But isn't it like, fortunately, unlike in many other healthcare conditions, MMR, maternal mortality rate as well as infant mortality rate is measured and seen as by global guys as well as a indicator for country, and there is a pressure somewhere for the Indian for every country to improve those parameters, and I think we have improved it, probably not enough, but even in other healthcare conditions, even those measures are not there. Measurements are not there. Fortunately, it is here. Even despite that, we lack the will to. You're saying in a way we lack the will to make it uniform across the country, despite the fact that these measurements are monitored at a global level and at a national level.
Absolutely. Just 2 months ago, you must have read in the newspapers that in Ballari Medical College, there were 3 women who died within 24 hours of giving childbirth. And the press report says that it was contamination of the fluids used to give intravenously to the mothers. I mean, we are in 21st century, reading about 3 mothers dying in childbirth within 24 hours in a government institution. We are equating ourselves to Sudan, an African country, not...
very preventable.
Very preventable.
Yeah. And so, one of the things in this, and we'll come to neonatology and pediatric care a little more, but just to close this topic, right? One of the things is, of course, government will, but even for that, is it more about having hospital facilities in tier 3, tier 4 places that have, say for example, technology in pediatricians from an availability perspective? So one is administrative will. From an availability perspective, we are reasonably okay now?
Infrastructure is already there.
Is there. So you're saying it's not a big infrastructure issue?
No, infrastructure is already there, and government has got enough funding, and the National Rural Health Mission has got so much of funding which has not been utilized properly. So it's the political will which will make the difference rather than anything else.
Oh, that's good to know. Yeah,
we are not short of money. We are not short of infrastructure.
That's quite because I kind of assumed that we might be short of infrastructure in tier 2, tier 3 places. But you're saying that's not really the case. Not much. I mean, little bit, of course, there will be.
As I said, it's a bigger topic for us to rather than cover. See, for example, a surgeon is posted to do pediatric work. A pediatrician is posted to do pathology work. I mean,
Yeah. Oh God.
those sort of things need to be surrounded.
So tell me one thing, going back to our topic of pediatrics and neonatology, how much is the difference from a skilling perspective between a pediatrician and a neonatology work? Is that that specialization a big step?
It's a huge step, because in neonatology we specialize ourselves to look after all sorts of premature babies. And premature babies, there are 4 categories. The extreme premature babies, which we call as less than 28 weeks, is something which a neonatologist only can look after, not a pediatrician. And that is a skill which you acquire by experience and exposure and practice.
And of course there will be a training component.
Absolutely.
Yeah. So yeah, great. So going back to a mother, right? So for example, to be a mother, someone is right now, say, all the pregnant women in this country, for example, what would be some of the tips? You've seen a lot of birthing for the woman as well as for childcare that they should do to improve the chances of a healthy baby and healthy mother.
Yeah. First, can I make a comment?
Yeah, please, of course.
In life, everything you need a license. To drive a car, you need a license. You need do a business, you need a license. I think to become a parent, we should introduce license.
That's a very interesting comment. I want to know more.
I think there should be some criteria of assessing everybody to whether they're capable of becoming parents.
What should be those criteria?
Well, I mean, if you want to become a parent, you need to dedicate time, because the child is dependent on you. And first 3 years of life, the child needs the mother and the father, of course. But many a times, a lot of people don't understand the responsibility. They just think they can have a child. So to have a child, you need to start preparing even before you become pregnant. You need to maintain a healthy lifestyle for you to conceive a healthy baby. And the nutritional aspects of the mother determines what the child's future is. There is enough research.
Yeah.
The Dutch famine showed that if a mother starves during pregnancy, if it is a mother undergoing starvation during the first trimester, the specific diseases are different. If mother undergoes starvation during the second trimester, the diseases are different. Third trimester, diseases are different. We call this as a fetal origins of adult disease. So the maternal nutrition determines what disease you get. Gone are the days when you say, well, I got hypertension or blood diabetes because of blah blah blah. No, you are destined to become hypertensive and diabetes depending on what your mother did during her pregnancy.
I love to go in this topic, right?
Yeah.
So say for example, I go back to your point. If someone is a real planner, right? Let's assume for a minute that they're really planning when to be pregnant and have a child. When should they start? And how should they assess whether they're fit or licensed enough to become a mother?
See, every parent, both the mother and the father, have to be healthy to conceive a healthy child and bring them into a healthy
So
world.
when you say healthy, what is that definition?
Well, I mean, alcohol, for example, smoking is not good because it will reduce your quality of sperm, it will reduce your quality of eggs, and eating junk food will definitely affect the eggs and sperm in a big way. And we see there is a lot of women nowadays with the polycystic ovarian syndrome, and it's many of them due to eating junk food and hormonal contaminated food. So you need to eat a healthy organic food, and you need to have balanced diet. Balanced diet is basically you consume 30% of your diet should be carbohydrates, 30% to be fats, and 40% to be proteins. And if you don't eat this food, then your body is disharmonious. So the chances of the mother developing high blood pressure, chances of mother developing diabetes during pregnancy, we call it as gestational diabetes, the chances of mother developing other illnesses during pregnancy is much higher. And we see nowadays 20 to 30% of our pregnant women become gestationally diabetic.
And how has that factor trend increased
In the
or
past,
decreased?
we never used to have this problem.
Oh, really? Yeah.
And that is the reason, one of the reasons why the number of cesarean sections are becoming more. Lot of mothers develop hypertension. Lot of mothers are developing hypothyroidism, which is underactive thyroid, because they don't consume the proper salt. They read all these WhatsApp messages and they start taking this salt, that salt. India is one country where iodized salt has been recommended by Indian Council of Medical Research for more than a few decades.
Right? Yeah.
And people still don't practice, and there's not education to the younger generation about the importance of consuming iodized salt. So we see 30% of our pregnant women who become hypothyroid.
Wow.
And in rural areas where they don't have antenatal care, you never know how many of them are hypothyroid and how many of them contributing to baby's IQ being affected.
So if there are 100 people giving birth, right? Today, how many would be C-section and how many would be normal?
It depends on the area of the or the city of the hospital, because for example, now we have Cloudnine across the country.
Yeah, you would be in a great position to know this.
So there are some Cloudnines where the section rate is only 20%. There are some Cloudnines where the cesarean section rate is 70%. So it all depends on
and
the population.
main difference is because of
The population.
Health habits or
Health habits,
or
health
something
habits.
else? Health habits.
Health habits. See, for example, if a woman undergoes fertility treatment, IVF treatment, there is no reason why they should have C-section. But the general feeling among all the obstetricians is, if a woman has conceived through IVF, let us do C-section.
Oh, okay.
In the past, there was no IVF.
Yeah.
IVF started only 40 years ago, or 47 years ago.
Yeah.
So the number of women conceiving through IVF nowadays is so high.
What would that percentage be?
At least in Bangalore, I would say 10 to 15% of pregnancies are conceived by IVF.
And 10 years back, what would that percent be?
It would have been less than 1%.
And what would be the main driving reasons for that?
Lifestyle?
It is
Lifestyle.
really only lifestyle, right?
Absolutely, absolutely.
And when you say lifestyle, it's basically the nutritional element or even the age has a parameter?
No, multiple factors, but the commonest is, see, to become pregnant, you need to have sex quite frequently. And normally what we say in medical circles is, if you are aiming to conceive, if you have sex 20 times, you may become pregnant once. But the number of times people have sex nowadays with their own partner is much less than much less than what is expected. Either because they both are working or tired and watching TV and distractions and things like that. So many people don't have as frequent sex as the people used to in the past.
So one of the simple solutions is actually might be just having more sex, is that?
Absolutely, absolutely.
Oh wow, that's a very revealing insight, because gosh, I mean, because they go through so much of pain and so much of anxiety to get the IVF done, but you are saying some portion of that can actually be avoided.
Absolutely. I mean, in fact, majority of the obstetricians agree that the couple don't have as frequent sex as they would suggest, which is the main cause of infertility.
Wow. So that's one. One of the factors that I had been kind of reading about was generally it's also attributed to late age pregnancies, which is that, how much is that true, or is it just more that anyway the lifestyle has been bad and this is just a additional
No,
factor?
ideally, see, the woman's egg reserve is what we call is very, very high before they're 30. After 30, the reserve's eggs will gradually come down. So the chances of woman getting pregnant beyond 30 will start slowing down. Similarly, man's sperm count, good sperms, quality sperms, will gradually come down after they're 35. So in general, once they both cross 35, the chance of getting naturally pregnant will be much lesser compared to younger age group.
Yeah. So going back to that license, I love that analogy. So going back to deserve that license, you said one is adopt a healthy lifestyle, right? So someone is say planning to conceive and have a child, they should first of all try to live alcohol and cigarettes, not touch that, have a healthier life, right? And then plan that within a year of that.
Once you decide that you want to have a child, your health is very important, because your health determines what the future of the child is. Then you need to also make sure that you can dedicate time to raise the child.
Yeah, that was another factor you said.
Yeah.
So elaborate a little more. When you say dedicate time, is it are you seeing a lot of things not being done that should be done today in terms?
See, for example, recently I saw one mother whose child was diagnosed with autism. But when I saw the child did not have autism. The child had what we call as a selective mutism. And there's a lot of difference between selective mutism and autism. And in fact, many healthcare professionals don't know the difference and they get confused.
What is the difference?
If a child is not talking, but in all other respects is normal, that's called selective mutism. The child refuses to talk. There's nothing wrong with the child, but child refuses to talk. Autism by definition is a different entity. Here the child's social skills are lacking. The child doesn't make an eye contact with anybody, doesn't want to interact with anybody, basically is a lone child and has got emotional, cognitive and various other problems. Whereas a child with the selective mutism does not have any of those cognitive difficulties, just refuses to talk. And this refusing to talk is very well documented in children who are exposed to screen time starting from 6 months to 1 year.
Oh, so really there is an evidence proved, it's not just a thing that people say.
No, there's evidence. In fact, most of the College of Pediatrics, whether it's Royal Australian College of Physicians, Pediatricians, Royal College of Pediatrics and Child Health in UK, American Academy of Pediatrics, Indian Academy of Pediatrics, everybody recommends no screen time for children under the age of 3. No screen time. Even after 3 years, they say maximum half an hour a day. But most of the children nowadays are fed,
yeah, well, I mean,
played
exactly.
by just showing a mobile with the game and things like that.
Yeah. And one of the common reasons, but I just wanted, this is so much in every house, and even very, very well educated houses, right? I mean, one of the things, a common reason that I've heard people giving, I don't have the authority like you had, so I could have told them, and now I will probably after this, is the child while watching eats, and we want them to eat food, and without showing it, they are not ready to eat. It becomes easier for the parents to feed if they are showing it. How dangerous and risky is this then?
That's the dangerous, because that's when they get addicted.
Exactly.
So once they see these colors moving, things like that, when they want to see that 24/7, and then they don't know how to control it. So they get one phone for maid to look after the maid to the child, and the child gets exposed to, then they get addicted.
And that can be a cause of selective mutism.
Absolutely, absolutely.
Wow, yeah. That's
the other thing which happens is, a lot of mothers I have seen ask me, can I give oats to my baby? And my first question is, have you seen what oats look like? No. Have you eaten oats? No. Then why you want to give? It's easy to give. See, if you start feeding oats to the baby because it's easy and you don't have to cook.
And oats is not good. It's not really very good nutrition.
Why you want to give something which you have not tasted?
Yeah.
I keep telling you, make the child grow like you. Use the natural things. You can use dry grapes, you can give fruits, vegetables, cut them. They learn to chew.
Yeah.
Oats, they swallow it like that. and then they get all other problems because they're not used to oats, this and that. I'm just giving you one example as
Yeah,
oats.
no, of course. I mean,
And the reason everybody wants oats is because it's shown on the TV. It's easier. Your child is fed easily. So forgotten are the skills of the motherhood, and they don't want to spend time either cutting a vegetable or taking care to cook something. And you start feeding all these sort of things and use mobile phones.
you're making very costly trade-offs.
Right? And
You're
that's where
making
I am
very
saying
costly
that unless you are ready to dedicate some amount of time to look after the child, you should not become a parent.
That's wonderful. How much the health of the father is also important before?
Absolutely, it's important. The quality of the sperm determines 50% of the quality of the baby. So
And that does get quite hampered.
yeah, definitely.
Wow. Now let's move towards this is amazing actually, because there are some nuggets here which I'm sure some of it I didn't know. I've grown up in a medical healthcare environment. Some of it of course I knew, but some of it I also didn't knew that this is the extent of the impact. Actually my father-in-law is a pediatrician.
Oh, okay.
As well, and I think now I will have more topics to talk with him. But going back to the other point, right? So one is, of course, if they take care like this. But now, say there's so many of them who have not taken that care. Already they have a kid. And before I go there, how many of the children today that are getting born are preterm? What percentage of people?
The preterm rates is about 10 to 15% in India.
And is that increased a lot over a period of time, or that's not really the case?
It has increased a little bit in the last probably 20-30 years because of high incidence of fertility and high incidence of hypertension in mothers and lifestyle diseases. So the prematurity incidence has increased. Global incidence is thought to be about 8 to 10%, and in Indian incidence is about 10 to 15%. So we're definitely heading towards 15% rather than less.
And those who have preterm babies, now you can't change that. Who have preterm, what kind of care they need to take? Is it a bad news always now, or there are many reversible things that one can do to improve? What are first of all the risks for a preterm baby in future?
So preterm is not necessarily bad news.
Okay.
I mean, the thing is, preterm, there are 4 groups. In fact, what we say is the full-term baby is between 37 to 40 weeks. 40 to 42 weeks is what we call as a post-term. Less than 37 weeks is what we call as a preterm. Now, in preterm, we have 4 separate categories. 34 to 37 weeks is what we call as a late preterm. Late preterm is by definition, most of them are bigger babies. The chance of jaundice is a little bit higher. And if you provide appropriate care in the first few weeks of life, they grow up normally and without any major issues. Now then comes the second group of preterm babies, which are 32 to 34 weeks. They are called moderate preterms, and
32 to 34
weeks. And those sort of babies really need a good neonatologist and good neonatal care to make sure that the transition from the intrauterine life to extrauterine life. And they, with the good care, they can do reasonably well.
So the neonatal care, if delivered well for them, reduces the future risk problems to a great extent,
Absolutely.
or some risk always remain?
Less than 32 weeks, the risks remain, but more than 32 weeks, ideally should not have risks.
If neonatal care is taken very well.
Is provided properly. Now, between 28 to 32 weeks is we call it the real preterm babies, and they are the ones who really need a good neonatal intensive care. And we talk about what is called as the intact survival. That means the baby should not have any disability, deformity as they grow older and become adults due to premature problems. And that can be delivered guaranteed between 28 to 32 weeks, provided you have a good neonatal intensive care looking after the baby at birth and before birth. Less than 28 weeks is a different kettle of fish. I mean, that's like what we call as the extreme prematurity. Now, we start resuscitating babies anywhere from 23 to 28 weeks. Just to give you an example, when I went to UK in 1990, UK was not resuscitating babies less than 28 weeks at that time. So it's a new concept. So when I finished my advanced training in the UK and became a neonatologist, I was very good with looking after babies 28 weeks and above. But when I went to Australia in Melbourne, they were pioneers at that time looking after the babies from 24 to 28 weeks. So we got trained in Melbourne even before UK was introducing that in saving babies from 24 to 28 weeks for intact survival. That means they should not have deformity, disability to go ahead. Not many centers in the world were doing that in 90s.
Now what do they do differently?
Because see, if the baby is born less than 28 weeks, it's virtually the whole body is premature. So the transition of the baby from the inside the womb to outside the womb should be so smooth. There should be minimal fluctuations of blood pressure, minimal fluctuations of heart rate, very minimal fluctuations in oxygen saturation. A slight deviation from this, a huge fluctuation in blood pressure or saturation or heart rate, their brain bleeds.
God.
So their outcome is going to be bad. And if there is a gross fluctuation of blood pressure, the first thing that will suffer is your intestines. So you will end up developing what we call as a necrotizing enterocolitis. That means the intestines becomes...
And managing all these needs more certain training and skill sets that are not done otherwise.
Not otherwise.
In your training, it's not.
Not otherwise. So this was the training which was there in Melbourne 30 years ago. And UK introduced this only for last 15, 20 years.
Do we have in India?
In India we have now, but not all the centers have. For example, in Cloudnine we have virtually every center, we have a neonatologist trained in this, but not every public hospital has got it. Not every private hospital has got it. So less than 28 weeks looking after is a special skill which should be regionalized, and everybody should not be practicing that. And if we look after those babies, we will have a replication of what happened in the US in 80s and 90s, where a lot of babies survive, but there are a lot of handicaps will evolve, and that is not going to be good for a country like India.
How many babies are... you can bring the coffee. How many, you said 10 to 15% of the babies are preterm. How many of them approximately, it's difficult to probably have data on it, I don't know whether we have data on it or not, but how many of them get neonatal care or access to a neonatologist in this country?
As I mentioned, I think urban areas are getting better.
Urban will, So the top 8 to 10 cities I think will get, but beyond
top
that...
8 to 10 cities also getting better only in the last 20 years.
And of course, I'm saying of at least as of now.
And rural areas, we still lagging behind in many areas, and there needs to be more political will, and it can happen. Like for example, medical colleges were sanctioned in the past without need for them to have a neonatal intensive care, whereas the new medical council or the National Medical Council revised criteria says that you need to have a neonatal intensive care. That came about only a few years back. So they should insist on these sort of things in the medical college curriculum, training, exposure, everything.
Is not there yet.
Which is, we are not there yet.
Okay. So now one thing is, if apart from preterm, are there any other specific conditions where a neonatologist plays a key role?
See, put it this way. If you have 100 deliveries, 90 deliveries, you don't need anybody. The babies cry on their own, and only 10% of babies need a transitional help from being born to cry so that their oxygenation to the brain is sustained. And in that 10%, one of them need advanced help where we have to intubate and give a ventilation.
And that's the role of a neonatal.
That is the role of
That's the
neonatologist.
specialized. Wonderfully.
So what we have done and in Cloudnine is we don't have any duty doctors. We have only post-MD doctors as working round the clock. So pediatricians only.
Oh. So all doctors are only pediatricians.
We don't have any MBBS doctor unlike many other hospitals.
Oh, okay.
We have only pediatricians, obstetricians and anesthetists round the clock.
And getting this in every Cloudnine is not difficult. You're not found this because many people say, oh, there are so many lack of doctors, we can't. Okay. That's really.
That's the reason we have limited ourselves to tier 1 cities. Yeah. If you can provide this in tier 2, tier 3, then we can do it.
I'll come to that. That's a very interesting topic.
So what happens is the 10% of babies who need help need help as soon as possible. Not
exactly.
See, in the past, before Cloudnine, what used to happen is an obstetrician used to do section, and they used to say, oh, this baby didn't cry, call the pediatrician, and he would have been at home or doing a clinic, and they'll say, okay, I'll come immediately. How bad is the urgency? A baby is not crying. He may take 7 or 8 minutes. That's too late for the baby.
Yeah.
How do you anticipate which baby needs? Yeah. That's why we made a policy that every baby, every delivery, a pediatrician attends. And the 10% of the times when you really need help, we are there.
Yeah.
We don't take chances. We don't take risks.
Right.
So that's exactly the reason why we started Cloudnine. Right. Because what happened is, when I left India, I used to see so many maternal deaths. I went to UK, I trained in the best teaching hospitals. Why I say teaching hospitals is teaching hospitals is referral hospitals, so normally you see much higher mortality. In 5 years when I was there in the UK, I didn't see any deaths of the mothers. Hardly saw any deaths in the babies. Then I went to Australia, I went to US. There was no maternal deaths. So I used to say, why are we having this problem in India? And they said, oh, in India it's different, you can't do this. So we started Cloudnine because we wanted to change the scope of the mother and baby care in such a way that we wanted to forget the maternal mortality and neonatal mortality in a big way. Right. And that was our passion and the dream to start Cloudnine.
Super. No, and I want to talk about Cloudnine in much more detail. But before that, I probably want to do one more thing, which is very interesting. A portion that I was curious about is now neonatology as a stage, if we leave that and get into pediatric stage, right? A kid is growing, doesn't have any major issues, but there are still milestones, nutrition, health, some are in sports, all of that. What kind of pediatric care in India, what kind of things are lacking or most parents miss out? Like you very nicely told about how time and health is two elements that even before birthing you really have to start looking at. But similarly, while doing a pediatric care, while growing up the kids, from a parenting perspective, in the context of health, what are the things that a parent should be doing?
See, in the past, when we did our pediatric training, we used to see a lot of children with malnutrition.
Yeah.
Like what you see now in Gaza and Sudan and other things.
We don't see that in India now?
No, we don't see that nowadays. So we used to see a lot of children with marasmus and kwashiorkor. Marasmus is a protein deficiency where the muscle mass is not there in the babies and their mid-arm circumference is like so we used to see quite a lot of children like that due to lack of awareness and various things. And I think the government took a lot of initiatives, and then National Institute of Nutrition, NIN in Hyderabad took a lot of initiative. So the protein energy malnutrition is what we used to call PEM.
Right. You might want to have
virtually is gone.
Yeah.
We have become really successful in treating them and avoiding them nowadays. We don't see that at all.
Right.
But malnutrition, spelled as MAL nutrition, is replaced now with the malnutrition, which is MALL nutrition.
Malnutrition.
So now we have a dual problem. We
You
have
say they're taking bad nutrition.
bad nutrition. So what has happened is, now we have eliminated marasmus and kwashiorkor, but now we have got children with a lot of micronutrient deficiencies which are not obvious clinically.
Yeah.
So unless you do a blood test, you don't find they are grossly deficient in iron, grossly deficient in vitamin D, grossly deficient in B12.
Would you suggest doing a periodic blood test of even kids who are healthy?
We don't need to do pediatric blood test provided they are eating a balanced diet and they're growing well.
But that's the challenge, right? Most of them don't know what is a balanced diet nowadays.
That's right. That's why if you're a mother...
So might be they do test and find out that it's not helping their kids.
No, that's what I'm saying. The mother, parent, this is why I said we need a licensing. Because one of the things which every parent needs to understand is what is a balanced diet, what children needs to be fed with. See, if they don't know what is balanced diet and they keep feeding them with the Pizza Hut or the Domino's or McDonald's, the child is not going to be super duper. I mean, he's going to suffer in some ways. That's why I said malnutrition. So we are replacing the malnutrition with the malnutrition and also micronutrient deficiencies, which is causing a lot of problems.
Amazing. Yeah, I think that's very interesting. So now we really shift the gears to Cloudnine. And you already told me that was one of the reasons why you did Cloudnine was to change this, which is a very clinical reason. The other thing that had captured always as a management and a marketing guy to me I was, for example, we used to talk about Cradle, right? You might want to, you just might want to turn that and take it, that it's different than any other healthcare facility because it delivers joy.
Yeah.
While in most of the other healthcare, you are really preventing death in a way, right? I mean, or something curing, which can lead to dangerous stuff. While here the environment though has a very lot of clinical angle, but it's really has to be of joy. And does that change the way you do service in Cloudnine?
Absolutely. Because this is why if you look at our vision and mission and what we did, what we call as pregnancy is not an illness.
Exactly.
Pregnancy is a wellness. A lady becomes pregnant by choice because she wants to have a baby and a healthy family. She doesn't become pregnant saying that I want to become ill and I want to die. So in that way, pregnancy is a wellness and not an illness. So they should not be going to a hospital. That's why we wanted to establish a center which we didn't want to call it a hospital. We didn't want to feel it like a hospital. We didn't want to smell it like a hospital.
Yeah.
Secondly, when you are well and you are expecting wellness to continue through pregnancy and you have a healthy baby, you are in a celebratory mood. You don't want to be stuck next to a person with renal failure or a person who has had amputation or a person who had a liver transplantation or a person who had a cardiac bypass and crying and various things, and you feel guilty to celebrate. So that's why birthing, we felt, needs to be separate from the multi-speciality hospital. So that was the genesis of Cloudnine, where we felt we want to focus on reducing the maternal mortality. We want to focus on good survival for the babies, including premature babies. We want it to not feel like a hospital, not look like a hospital, not treat like a hospital, and it feels celebratory. That's exactly what Cloudnine is all about.
No, that's wonderful. And anything of that nature to scale, right, has to be economically sustainable. There has to be an economics behind having Cloudnine or any birthing center to be. What is the economics today? Like, how does, I understand Cloudnine is about 40 centers?
42.
42 centers as we speak. It
As we
is,
speak, and
it
there will
goes
be 43
42 centers, right? Huge, right? And in almost 13, 14 cities, if
Yeah.
I'm not wrong, right?
14 cities.
How does this model work from an economics perspective? A broad idea of what kind of revenues get into different streams. How does this? What's the what's the economics behind Cloudnine?
See, the economics was secondary when we started Cloudnine. In fact, I have to tell you this incidents. We were only 1.5 month old facility, and I still remember this guy delivered in room 106 in Jayanagar, and he had just finished his financial MBA. He felt overwhelmed with the experience he had, and he said, I've heard so many of my relatives having childbirth, nightmares.
Exactly.
You made us experience such a fantastic. So in return, I want to give you something. I said, sure. So he gave me an envelope and he said, read it once I have gone home. So I opened that, and he had finished his MBA finance. So he said, thank you for the wonderful care, but you please follow my Excel sheet. And he had prepared an Excel sheet. What it showed is, he said, in the current rate, if you continue like this, you will break even after 15 years.
Right.
So
that's what I said, right? I mean,
I would suggest and recommend that you convert this into multi-speciality hospital.
Okay.
That was his recommendations, considering that. I said, if I start a multi-speciality hospital,
defeat the purpose.
Then defeat the purpose.
Yeah.
So, surprisingly, he came for a second baby 4 years later, and he said, my MBA is useless, you've proven me wrong, and you're doing very well, I can see. I'll take my words back.
So help us understand, though anyone who's wanting to say enter today, is an entrepreneur, want to enter into mother and child birthing, from an economics perspective, what should be he looking at? He or she should be looking at. How does it look like as a business?
I always say this to people. See, it's like the Bhagavad Gita. If you have a passion, you start. If you think you are going to make money in this and that's why I want to start, that's a bad start.
Yeah. No,
So,
I don't mean only to make money perspective, but also it has to be sustainable, right?
Yeah. So what I'm saying is, you should not look at, well, I'll make a lot of money in this and I want to start. That's a bad start. Anything an entrepreneur should start should have his passion, vision, and motivation. If you don't have the passion, vision, and motivation, and you start with the view to make money, that's going to fail.
Agree.
Money is secondary. Money will come the moment you show success. Prahlad's book, Bottom of the Pyramid, says, I'm sure most of us have read.
Yeah, one of my favorites, yeah.
That clearly shows it's a numbers game. The more you treat, the more you get revenue. Volume is different. Otherwise, you want to remain exclusive, you charge a bomb and you say, I want to provide this. So both will work. And the good thing about India is a huge country
Has all of
with a 1.4 billion population. Doesn't matter what you do, where you do, you will succeed provided you do it right. People who fail are the one who don't plan well, or the plan thinking that they'll make money. That's a wrong start. Now, we started Cloudnine because of passion. We wanted to improve the standards of maternal neonatal care, including the morbidity. Nobody talks about morbidity. When we started Cloudnine, we looked at 23% of mothers used to silently suffer some sort of pelvic floor damages, including incontinence. And we wanted to avoid. Now today I can boldly say we have 0% maternal morbidity among Cloudnine mothers. We have physiotherapy both before pregnancy, during childbirth and after childbirth, keeps their pelvic floor intact, and they have not had any morbidity at all. 23% of mothers used to suffer silently because when you have a pelvic floor damage and incontinence, and they were used to be told that this is a norm, welcome to the club. So what I'm saying is we started Cloudnine with the vision to improve the quality of maternal care, quality of maternal neonatal care, to reduce the morbidity, mortality and other things. And that itself brought extra business and work, and the result is today.
Yeah.
We have got 42 centers.
So one of the other things, right, again, you know, if I look at not from money angle, but from a business angle, right, in terms of sustenance and what should be done and things. One of the things that I hear about, right, and when I do, so we did a lot of market study around many things in mother and child as well as pediatrics at my firm in Inside Tribe. But one of the things that we come around is there are very few examples of people doing extremely well with only pediatrics. And one of the notion or hypothesis was that if you have mother and child and pediatrics together, it is more sustainable and easier to do. Is that right way to look at it?
Well, before we started Cloudnine, everybody said it won't succeed. I was just telling you during the coffee break about the experience with the MBA finance degree.
Right.
And that clearly shows the belief they had. And they said mother and baby doesn't succeed. Until somebody proves and they have a good sustainable model, they'll always say it's not sustainable.
So just because lack of, so you are saying there are lack of examples that's making people think like that. It might not necessarily be true.
Absolutely.
Someone can build a model.
In fact, I'll tell you what, when we were 1 year old, my teacher and my mentor needed cardiac catheterization, and he had a stent put in. And we went to one of the hospitals here, Fortis, and he got admitted at 6 o'clock, got discharged at 3, and his bill was 3 lakhs. And the CEO of that hospital came and made fun of me, saying that this is how we make money, not looking after the mother and baby for 72 hours and charging 50,000. So each person's perspective
is very different.
Very different. A person who has seen 3 lakhs bill for 6 hours stay and ICU.
That's not the way to look at it, first of all.
Will not be interested in mother and baby. So everything is sustainable provided we have good numbers, good quality of care is provided, and children's hospital across the world
is doing extremely well.
Extremely well. I mean, if you look at US, Children's Hospital of Philadelphia is one of the most successful organizations. Boston Children's Hospital is very profitable.
Absolutely. And that goes back to that topic that I was earlier talking, and I would love to know more on that. Is Cloudnine has, as you rightly said, you know, it has become, is there in all tier 1. What is the next step for Cloudnine if they had to? Is Cloudnine feasible to do in tier 2, tier 3 places? Would you need to change the model? How do we have more Cloudnines across the country?
Well, India is a huge country with, as I mentioned, 1.4 billion population. So we have not exhausted India yet.
Exactly. The tier 1 is, I think, very well established that you can make a sustainable model delivering care in tier 1 in Cloudnine. What would you say about tier 2, tier 3?
Yeah, tier 2, tier 3 is definitely possible, but the model has to be different. Because what happens is our infrastructure cost and our cost of paying the doctors is very high in tier 1 cities. And tier 2 cities, definitely the paying capacity will be less. So definitely the paying of us to the doctors will be less. So we need to have a model where we can work and we can make it successful. It's not very
What would be the key critical factors to make it successful? What would change if Cloudnine has to be in
the size makes a difference.
Okay.
So what we will have to do is we'll have to make more hub and spoke model for tier 2, tier 3 cities, because in Cloudnine in tier 1 cities we have, for example, neonatal intensive care, catering for all sorts of premature babies, which is quite an expensive investment, the incubators and this and that. So in tier 2, tier 3 cities, probably what we can or we think we should do is maybe have not that much of capacity, and if any baby less than 28 weeks needs a care, then we ship them across to the tier 1 cities and cater. In that way we retain the expertise, then we reduce the infrastructure cost and looking after the cost, and definitely provide a better care. And this sort of care is very well known in Australia or
and you see a sustainable model at a lesser price points.
Absolutely.
In tier 2, it's sustainable. We can build that kind of a model.
We can.
Are you thinking of building one or not yet?
We have already done 2 cities. We have done in Ludhiana and we have done in Lucknow,
Which has a very different price service mix.
and they're all already both successful.
Oh, lovely.
So they both are tier 2 cities, and in fact Ludhiana is one of the first experiments we did, and we are very, very pleased to say that we are doing extremely well there. And we have done in Lucknow. Again, Lucknow is doing extremely well.
Lovely. Oh, so that's a great example. That's very encouraging to know that this can, as a model, really be. In terms of gaps, right? So if you were 20 something or early 30s right now and had to do something in mother, you had an interest in mother and child and pediatrics and all of that, what would you do what kind of gaps today exist that if you had to start now you would have done today?
There is still quite a lot of things we can do. See, when we started Cloudnine, everybody said, well, we have virtually satisfied Cloudnine things. But that's not true. We have evolved over the years. In the last 18 years, if you look at it, when we started Cloudnine, we didn't have home care. We provide home care now. Any mother who delivers a baby who feels that she is overwhelmed or the parents are overwhelmed or they have premature baby, we provide home support, home nursing care, home everything for the first 2 weeks or 3 weeks depending on what they need. Then we have virtual consultations. See, when the mother has gone home, suddenly she decides to go to mother's place. She doesn't need to travel anywhere. She can do video consultation, teleconsultation is possible. So at the click of a button, she can request all the medications from the pharmacy. Pharmacy will deliver through whatever means to their house. They don't have to come out. If they need any consumables like nappies or whatever they need, that is provided from the hospital. So the amount of services we have started delivering at doorstep is almost like Swiggy.
Yeah. So you're saying there is a lot of service around this that someone can, as an entrepreneur, can come and address.
Absolutely.
Right.
So these are all the things which we have done, but there are lots of other things which we can do. I mean, there's the parental education can be taken. They can, I mean, there are, in fact, we saw one app which talks about educating the mothers about what foods which we prepare.
I was thinking about it when you were talking about the need to tell them the nutritional.
The problem is, see, what happens is we usually advise continental diet, but the diet in Kerala is different from diet in Tamil Nadu. The moment I talk about ragi as the first food to be given, the North Indians look at and said, what ragi? No.
We don't have it.
They think that if you give ragi, the baby will become black. So they have different concept.
Wow.
So each state has a different needs of the diet, and people can, regionalize the diet and give. And we found recently one app which we incorporated into Cloudnine app. So the mothers actually now can look at what they can feed depending upon what their region, what their preferences, and they learn. So a lot of things can be done.
How much of technology, right, going back to your neonatal especially care and as well as in pediatrics, how much of technology is playing a role? How critical it is? I mean, it does play a role, of course, I know from a tech perspective, but,
we are,
how critical it is?
We are actually very, 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 very focused on technology. We are so much focused on technology. As I mentioned, we were ready with the teleconsultation even before pandemic. But fortunately, the pandemic gave the license for us to think. So we actually had a platform ready. We launched on the day the government gave permission.
Oh.
And now we are using artificial intelligence, which we are probably one of the very few, maybe we are one of the only hospital in India who is using artificial intelligence in a very big way.
You're generally answering the next question before I was asking. That's excellent. It's a great secret. I was about to ask, how is AI really, is this really
So that is the best example of technology I can give you. So what happens is, when a baby is born, admitted to NICU or a neonatal intensive care, we don't know whether the baby is septic or not until the blood culture becomes positive 72 hours later. So now we have incorporated AI in looking at the baby's heart rate, saturation, temperature, behavior, color, turgor of the skin and all that. And we can tell by AI that this baby is going to become septic at 12 hours.
Really? You can predict?
You can
based on the current parameters?
Current parameters.
And that changes the treatment path quickly?
Absolutely, absolutely. Then we've also incorporated AI into the what we call as a hospital management system or HMS.
And this AI is made in here in India or?
No, we have inbuilt team.
You've built it on your own an AI?
We have an in-house team.
Oh, lovely.
Working on it.
Oh.
So we have incorporated AI into the hospital management system, which can actually predict a woman who walks in whether she is going to have a premature baby or not, to the extent of 80% prediction. A clinician can predict only 20%. We have done the study. We are about to publish that in a journal now.
Excellent.
So we are very, very well advanced in technology.
And this you see playing a bigger and bigger role, especially in predictive.
Absolutely.
You see AI. And what about medical technology in the sense, so the reason I'm asking also from my interest in the sense, I used to sell warmers and all of the GE equipments, right? How much of those kind of technology, is there any gap today or
absolutely,
or something that we from a medtech perspective can do to better neonatal or pediatric
Remember
care?
When we bought your giraffe from GE,
Kangaroo Care.
You had GE trying to sell giraffe in India for 3 years.
Yes.
You had not sold anything.
Very few.
And we were the first one to buy 14 giraffes in one go. And now we have giraffes everywhere in
and it does make a lot of difference, or we overestimate because we are from technology?
No, it makes a difference. It's like a Rolls Royce for babies. Because when the babies are born premature, we need an artificial womb. That is like an artificial womb.
It is as close as it gets.
Now, when we started Cloudnine, I'm sure you remember, what was the phototherapy equipment? It was tube light. 4 years down the line, suddenly LED replaced everything.
Lullaby LED.
We were the first hospital through all our tube light phototherapy units and replaced with our LED overnight. We didn't think of the cost. We didn't think of refurbishment. If you go to rural areas, even today,
the outcome of a neonatology care that you mentioned, apart from an access to neonatology, which probably is the most important, but this do make a difference in the outcome.
Absolutely. So since we replaced the tube lights to LED, average length of stay for a jaundiced baby is just 1 day.
Reduced. Fantastic.
Before it used to be 2 to 3 days.
Fantastic.
If you go to rural areas, even now it's all tube lights. So most people who come to Cloudnine don't realize we have the state-of-the-art technology in everything, starting from equipments to software to everything, to give them the best service we can. And that's why our average length of stay is much, much, much less compared to anywhere else. In fact, even if you look at the obstetric guidelines of India, of the FOGC, they say cesarean section ladies need to stay in the hospital for 5 days. Why? For 18 years, we have been discharging mothers 48 hours later, whether it's a normal delivery or a C-section, because early mobilization reduces the outcome, fatality outcome, and you don't need to get stuck in a bed for 3 days. And India needs to evolve. We have reduced the average length of stay from 5 days to 2 days, and our mortality is the lowest in the world because we are part of Vermont Oxford network. We can compare our stats to the Western world.
Wonderful.
And our outcomes are the best. So we have reduced. So technology early mobilization, adaptation.
So recently, this is lovely, and I think this is one of those areas where lot can be done, and also example which gives us also confidence from a technology sector that that makes a difference, right? Other thing we at Insight Tribe did actually a study for a pediatric clinic chain who's wanting to enter India, and one of the study insights that I found was, and I wanted to test with you whether that's how true is that, we interviewed about almost 50 mothers and 30 pediatricians. One thing we realized is that this whole autistic spectrum and wellness and ADHD in pediatrics, that's kind of underserved area. A lot of mothers still don't know what to do if that is the case, and what should be the ideal outcome, even in affluent India, right? I mean, forget about tier 2, tier 3, even in tier 1. Is our reading right? What are your views as a specialist on this?
Absolutely. See, the child, what we call as a special needs child, is not met with in India. In fact, if you see a parent having a child with the Down syndrome, for example, that needs a special care, special education, we are not catered. I mean, autistic children, I feel empathy and sympathy with the parents because they run from pillar to post to find a cognitive therapy and various
Exactly.
Not everywhere it's available.
So you see that as a big need that can be actually services around that can be really built a lot?
See, that's a specialized area which needs to be supervised and catered well with the special training people.
We don't have that.
Quality trained people and availability around everywhere, it's very difficult because number one, we don't have too many well trained people. Number two, if you identify somebody, retention and remuneration becomes challenge because these sort of people suddenly uproot themselves and go abroad because their future is much better abroad than here. So,
and generally what what training they need? Like a pediatrician is not fully equipped to handle
it's
this?
a team which needs.
Yeah.
You need a developmental pediatrician.
Right.
To assess the development of the child and follow it up regularly. Just like we have neonatologist, the developmental pediatrician is a separate entity. Then we need occupational therapist, then we need a physiotherapist, then we need a psychologist for cognitive evaluation and assessment, then we need a sports therapist, then we need a child psychologist who can play this and that, and then we need a nutritionist who specializes in the nutrition of the children, because they will have all sorts of fussy nutritional requirements. Either they may not like the sugar, or they may not like some food which has got some different consistency. So you need all sorts of people, and we don't have.
So this is, in a way, you are saying this is what 15, 20 years what neonatology was to the world, India. This is probably in a similar stage today, under-addressed, under-penetrated because of lack of people, but yes, there is a big demand, but under-penetrated in a
Absolutely.
way.
So once you have all these people, then you imagine it's a teamwork.
Yeah.
It's not a single person who can do things.
I think that's, so
what happens is when you pay for all these people, unless you have numbers,
it's difficult for sustaining
or
it.
you have a paying capacity as a Murphy's law, a person who needs can't afford to pay, a person who can pay will not have this sort of needs. So, then its sustainability becomes a difficult issue.
And insurance cannot really tackle this. We are far away in India too.
Right now, with the great difficulty, NNF has fought and included newborns into the insurance. Otherwise, newborns were excluded in the insurance in pregnancy.
Oh God.
So only for the last 1 year, I think newborns are included in insurance. So including these things will take a little longer time.
No, so that's great, wonderful. So what next for Dr. Kishore Kumar?
What next? Right now,
I understand you have kind of, we were talking earlier and you mentioned now a lot of Cloudnine is so well managed that you have to overlook things, right? But that is one thing I would love to cover, this journey from one to many. What would be the leadership lessons for others to take from this? How did you made that grand? One was, of course, discovering that there is a need for it, you mentioned earlier when we were talking earlier, but the non-clinical challenges and how you solved them, I think it will be inspiration for many clinicians who become as an entrepreneur. What are some of those big ones and how do you solve those?
Well, the leadership in healthcare is quite challenging, because when we started, I felt like Rama, for example, with all monkeys around, because Rama went to invade Lanka, but the monkeys will do whatever you tell them to do, but they didn't have any thought process by themselves. That's exactly what happened. But after some time, once you have trained people, you created more leaders, it becomes more like Krishna. You become, chariot, and you led the whole team to do their job, what they need to do. That time you need to take a seat back.
How difficult that was for you? That transition?
It's difficult. The transition is difficult, and I think definitely Croton will, the other trainings definitely made things much more smoother. But it is something which is not easy, because what happens is when you have led the team as Rama for a few years and suddenly you realize now they're all capable and they can do themselves, you need to trust them to do what they need to do, and you need to take a back seat, and that takes a lot of effort to pull yourself back and say, let them do themselves. And that's what we did, and that's why it's the Cloudnine today what it is.
So what's next for Dr. Kishore Kumar? How do you plan to, what are your motivations now that you have set?
Right now, I'm focusing quite a lot on research, because we have 18 years of data. And India,
so the researcher in you, which was born in under the mentorship of you, now is getting more traction?
Absolutely, absolutely. Because what has happened is, we have a lot of data in India, but we have never published.
Exactly.
And that's why we are probably lagging behind. And now what we are doing is we are publishing the data what we have for last 18 years in many international journals, raising awareness about what we are doing, starting from whether it's newborn screening for all babies, whether it's
how useful it is, newborn screening, genetic screening.
Very useful, very useful.
We have very less, right, in India? Or it's now become quite regular?
No. See, it's all like, there is a saying, what the mind doesn't know, eyes don't see. So if you don't screen them, you don't find them. Now we have been doing screening for last 18 years. We have found so many diseases. One of the reasons why our infant mortality rate is less than 1% or 1 per 1,000 is because we are doing newborn screening. Had we not done the newborn screening...
What are generally the big catches that...
We have identified almost 500 babies with hypothyroidism at birth. Had we not screened,
we couldn't have.
In 18 years, we would have made 500 babies become mentally retarded within 2 weeks of birth.
But you could prevent that because you found it?
Absolutely.
Really?
Yeah.
There shouldn't a lot of clinics be doing this?
Absolutely.
That's why they don't?
That's why we are shouting from the top of the world, saying that this should be made a national policy.
Do you see a lot can happen in the outpatient clinics of pediatrics which is not happening right now?
Absolutely. In fact, 3 months ago, I saw one baby who came from T. Narsipur, who was 1-year-old child, who was weighing only 4 kilos. And the reason he brought is he saw his boss's child was 4 kilos at 3 months, and this child was 4 kilos at 1 year. And they had gone to Mysore Medical College and various other hospitals in Mysore, where they had done MRI brain, chromosomes testing. Everything was normal, and they were told nothing wrong with your baby. And all that I did was newborn screening, and I found the TSH, which is the hormone which controls the thyroid, was normally should be less than 10. It was 2000 plus. So basically, baby had an underactive thyroid.
And a lot of the patients will come to an hospital much later than first direct is the access to the pediatrician who's doing in an outpatient clinic, right?
Yeah.
And a lot of testing there today, you see a gap.
Absolutely.
That is not happening. So there's a lot to be done in outpatient, I think,
Yeah.
from a clinic perspective. That's lovely. Yeah. So going back to, so you now want the researcher to come.
So
and
we are collating the data and publishing a lot of data to show that we are doing excellent work in India, and we are part of the international organizations like Vermont Oxford Network, and quality of care in India is no different from anywhere in the world, provided you need to follow this 1, 2, 3 thing. So we're trying to educate everybody and things like that. So that's where I'm focusing on education and research and motivation of the younger generation to do more research.
Lovely. I think that's great, and I'm sure that there will be a Cloudnine version of all of this at multiple places in terms of research as well. I think there's huge scope for India to do research. I completely agree with you. Great. So one of the things, right, as you grew from 1 Cloudnine to 40 Cloudnine, right, I get the picture of the clinical excellence and all of that, but you need financing, investment to grow this. How did you map this investment journey?
That's a very, very important and interesting question. Healthcare sector investment is different from my .com company, for example. When we started the first Cloudnine, we had angel investors, and angel investors lost patience after 1.5 years, and they said, we've invested with your passion. I know we are making a lot of name, but we have not got any dividends. When are we going to get our returns? That was their gross first. Then we had borrowed unsecured loans from people whom we are paying 18% interest.
Oh, wow.
So at that time, I felt this is unsustainable. So what I did is I offered them shares in the company. And because we were making a lot of name and brand was becoming popular, they happily accepted it, fortunately. And that was a break even.
So rather than going the debt way, you went to diluting equity.
Diluting equity, and we gave a small portion of our shares, and that reduced our cash flow and burning. Then when we wanted to expand, which came organically because a lot of parents started asking, you're doing such a wonderful job, why don't you start a branch in North Bangalore, why don't you start a branch here? So we thought, yeah, it's a good idea, why don't start? And then we started looking for funds, and getting the first investment was very, very difficult because most private equity investors did not have a clue about a mother and baby, nor they were interested in investing in mother and baby. So it took a lot of effort, and to extent that after 1 year, I literally gave up talking to private equity investors.
And you were doing all this on your own, parallelly with managing the center as well as working with this?
I mean, we had people allocated team, yeah. But then finally one day I got so fed up and I said, I'm not going to do this anymore, no more interaction with any private equity investors. So finally one day Matrix Partners came with the appointment through somebody and said they want to invest.
Who came? Sorry.
Matrix Partners.
Matrix Partners. Okay.
Avnish Bajaj and Ashish Mahapatra was there at that time. So I was very ruthless with them. I said, what is your decision process? What experience do you have healthcare? When do you expect returns? So instead of them interviewing, I interviewed them, and they had answers for everything. They said, we are only 2 of us will take the decision, Avnish Bajaj and Ashish Mahapatra. And we will take a decision within a week. And so we sort of clicked the deal. It was like a love at first sight, you know. And
what was that level of investment, if we can share?
That was the first investment, which our company was valued at 100 crores. and they put in 45 crores, which
Was important for you to grow.
major investment for us to open the second and third branch in Boulder.
And this was at the stage of first. So you had one center at that time.
China.
And this was second and third. Yeah.
This was the second and third. So that was a major boost. They say no, first million is the hardest and second.
hardest.
So after that, everybody saw the growth, and after that we had investors coming like honey bee coming for things. So now we are cash surplus, but people want to invest now. So
And how big is the valuation disclosed for Cloudnine right now?
right now, officially, we are valued at 6,500 crores.
Wow. Wow. That's wonderful. So this is a huge growth journey, and there will be many investment rounds that happen. And what are so entrepreneurs who are in the early journey, say who are there in the Cloudnine first journey in healthcare, right? Not necessarily mother and child, but anyone. What would be your tips to deal with venture guys, PE guys? What would be some of those tips to partner investment?
So I always say this, I've said this last week in Seychelles, venture capitalist is like getting married. You need to find the right person, or right investment partner. If you get a good investment partner, your life is made. If you get a bad private equity investor, then your life is like a marriage, it goes down. But what you need to do is, when you find a right investment partner, you need to talk in your language rather than buckling under pressure and talking their language. And don't promise any returns which they want you to promise. If they want to invest because they believe in you, let them invest. And you do the investment because you want growth rather than money. And you should not focus on only money, because money will come if the growth happens. So those are the two things. And certainly you should not underestimate yourself. You should definitely have the confidence that you can deliver what you are planning to. And you should always have an upper hand in the discussion with the private equity people rather than them taking the upper hand. Otherwise,
in any point of this journey, right? Any point of this journey as an individual, right? Were you ever felt or ever were scared that, oh, I'll run out of money, or I'll become bankrupt, or?
That is something which I keep thinking back. We never felt that.
You never felt that? Yeah.
We never felt that fear. Had we felt that fear, I don't think we would have grown.
Okay. So you didn't have to deal with that fear of things were in such a way that you didn't felt that for whatever reason. Yeah, lovely. So let's end up with a couple of things just for the audience as well. Is what are some of the myths about childcare that you frequently see, which are real myths? Like things like ये करना चाहिए बच्चे के लिए बहुत अच्छा रहता है types.
The myths are there everywhere in the world. People think that myths are present only in India.
Oh, no, of course.
And the commonest myth in pregnant women is, if you take saffron, for example, you will have a fair complexion baby. Now, if you get a good complexion baby, they'll say, I told you so, it worked. If you don't get a fair complexion baby, then they'll say maybe you didn't take the right quantity, you didn't take the right amount at the right time, or maybe it's Chinese made and things like that. So,
right.
Saffron doesn't give you definitely white quality baby. It definitely genetics. And there is a strong myth that pineapple causes abortions, and there is no way pineapple causes abortion unless you eat only pineapple for breakfast, lunch and dinner. Even then the chance of abortion is much lesser. But for some reason, people who love pineapple stop eating pineapple because they think that they will get a miscarriage, and that again is a myth. In the childcare also, there is a lot of myth saying that they have to give honey, sugar, barley water, tulsi water. They don't understand that a baby loses weight in the first 1 week of life. First 1 week of life, mother recovers from childbirth and produces enough milk only after 1 week. And that's why all babies lose weight in the first 1 week, and then they recover their birth weight after 2 weeks. Now, majority of the times, when I say majority, 90% of the times, mother's milk alone is enough. And if they continue to feed, and they get enough support with the breastfeeding, then the baby will do well. very, very rarely we need to give extra feeds if the baby loses more than 10% of the weight within 48 hours. That's why we check the baby in 48 hours, we check the baby in 1 week and all that. So as a rule of thumb, you need to monitor the weight of the baby in the first 2 weeks of life to make sure that the baby is doing well and mothers are doing well also. And there is no need to give honey, sugar, barley water, tulsi water, which was the belief in the olden days, because mother's milk is not enough. And nowadays, if the baby needs anything extra, we definitely give a little bit of artificial feeds. Otherwise, we don't need to give anything.
So there was this, I was reading this book called as Garbha Vidya. That if you talk to a womb, the development of the baby is better. Is there any truth, evidence in it, or is this a myth?
No, there is a lot of evidence in it. In fact, we have the famous Abhimanyu listening to story, and people think that's a myth, but that's not true. In fact, there's a Harvard Medical School, Boston Children's Hospital have done studies showing that if a mother talks to a baby in the incubator who's a premature baby, the heart rate of the baby is much calmer, and babies respond to the mother's voice after they're born, which suggests that the baby recognizes the mother's voice. And in fact, some hospitals have even experimented putting mother's undergarments like bra and the clothes in the incubator, and the smell makes the babies calmer. So definitely babies respond to the mother's and parents' voice.
So there is a grain of truth. Abhimanyu might actually have learned Chakravyuh in that time.
Absolutely.
Thank you so much for that. It's so lovely to have you and have this conversation. I'm sure a lot of us, I love the fact, I think license, right? License to be a parent is something that people should really look at, and the way we're bringing the next generation, that I think there is some responsibility. You make me feel more responsible as in parenting after I hear you. But wonderful. Thank you so much for having being here.
Thank you.